Good evening. I want to welcome everybody to this week's session of Sage's Dermpath Happy Hour, Dermpath Unknowns. For those of you who will be able to view the deck ahead of time, we have a nice mixture, I think, of inflammatory and neoplastic conditions. Didn't want to leave out cysts or deposits either. If you have any questions at all about any of the cases, I'll be checking the chat for those of you who are tuning in live. If you're watching the video later or reviewing it and have some questions, you can always email us at education@sagesdx.com, or you can email me directly, tdavis@sagesdx.com. So without any further hesitation, we will go ahead and get started. Slide one, the specimen is an incisional biopsy. This particular incisional biopsy specimen was from the distal lower extremity. And how do we know this is from the lower extremity? Well, the dermis here is relatively thin. We can see a fair amount of fat. And if we zoom in and look at the papillary dermis, we can see that there's an increased number of slightly thick-walled vessels, little subtle nodular angioplasia here, which clues us into the fact that we are on the lower extremity. The process clearly here is a neoplastic process, and within the subcutaneous tissue, one can see a very well circumscribed, very symmetric neoplasm. This has a very benign architectural silhouette. And as Dr. Vandergaard pointed out in last week's happy hour, when we're looking at a neoplastic process, you want to start at low power and assess the architectural configuration, looking for size, circumscription, symmetry, etc. You also can see zones of necrosis at low power, not in this slide, but anyway, those are the types of things you want to look for. And here we have an architectural silhouette that's very benign. And as we move in and look at the tumor at higher power, we're going to want to make sure that the cytology, the nuclear morphology of the cells comprising the neoplasm is also suggestive of a benign tumor. As we move into higher power, it becomes clear that we're dealing with a mesenchymal tumor here, that is one that's not composed of epithelial structures or epithelial structures in nexal epithelium. There appear to be some hypo and hypercellular areas within this tumor. And if we move to higher power, we can see that the tumor is actually composed of fascicles of spindle-shaped cells. Some of the fascicles are cut in cross-section, as we can see over here. Let me circle that. And some of the fascicles of spindled cells are cut longitudinally. And if we look at the longitudinal areas, the areas have been cut longitudinally, we can see that the nuclei have spindled or fusiform shape. These are kind of large, blunt-ended nuclei, whereas those that are cut in cross-section are more round. Note that there are perinuclear vacuoles here, that the cells have fairly abundant pale staining cytoplasm, and the cytology is suggestive of a benign neoplasm. The chromatin patterns very uniform. There's not much in the way of nuclear pleomorphism, and there's no necrosis or mitotic figures. Now, interspersed between these fascicles of spindle cells, one can see slit-like vessels. And these slit-like vessels have smooth muscle in their wall, and the smooth muscle kind of merges in a very inconspicuous fashion with the fascicles of spindle cells between the vessels. The correct diagnosis in this case is an angioleiomyoma, and we could confirm that with the use of a smooth muscle actin stain, which would highlight the cells comprising this lesion. The angioleiomyomas tend to be very well circumscribed. They're usually located in the subcutaneous tissue, and the distal lower extremity is a common location. These tumors can be painful. They've got a very distinct appearance on scanning magnification. One sees typically a very well circumscribed pink ball in the dermis. And really, there are only a couple of things that give you this well circumscribed pink ball in the dermis. One of them is a pilar cyst. Pilar cysts have pink homogeneous keratin centrally, but a pilar cyst would have an epithelial lining out of the periphery composed of stratified squamous epithelium, which we don't see here. A couple of other tumors that can have this architectural configuration are schwannomas. Schwannomas, of course, tend to be much more cellular than angioleiomyomas, and they tend to be composed of mixtures of Antony A and Antony B tissue. The nuclei also tend to be a little tapered and not so blunt-ended. And finally, a giant cell tumor tendon sheath can have this configuration as well, but of course, it's much more cellular and has the characteristic osteoclast-like giant cells admixed with usually sideroblasts and lipoblasts, and has a different cellular makeup. So first case, angioleiomyoma, we can confirm it with a smooth muscle actin stain. Interestingly enough, Desmond, which we also use for a variety of smooth muscle neoplasms, does not stain vascular smooth muscle well. And so a lot of times you get very patchy, if any, stain with Desmond in the setting of an angioleiomyoma. And let's go ahead and move on to case number two. Case number two, the specimens of bisected punch biopsy, relatively thick dermis. And, here's one follicle, terminal follicle with some sebaceous lines, but not a high concentration of follicular and sebaceous elements here. And so this is very characteristic of trunk or proximal extremity. Here we're dealing with an inflammatory dermatosis. And we can see that the infiltrate's predominantly centered around vessels of the superficial vascular plexus. As we move to higher power, we can see that the infiltrate spills out into the interstitium and actually takes on kind of a band-like configuration. So the papillary dermis appears to be thickened, and we have this patchy band-like infiltrate of cells within the papillary dermis. Furthermore, beneath a basket we've quantified there, the epidermis is thinned with effacement of the reedy ridge pattern, and there's actually a vacuolar interface dermatitis. You can see holes punched in the basement membrane zone across the biopsy specimen, coupled with the presence of necrotic or dyskeratotic cells, which are the histological hallmarks of a interface dermatitis, so the vacuolar type, with this kind of patchy lichenoid infiltrate of lymphocytes within the dermis, which doesn't really obscure the dermal epidermal junction. Admixed with the lymphocytes, there are several pigment-laden macrophages. And if we look at the overlying epidermis, we can see there's an increased amount of melanin pigment within the basilar keratinocytes, indicating that this is likely skin of color. And anytime you get an active inflammatory dermatosis, and especially an interface dermatitis in skin of color, you tend to get a lot of pigment dropout. And so these pigment-laden macrophages are actually melanophages, and they're present in number. Now, there is not a tremendous amount of specificity with a biopsy like this. The changes really generate a differential, which need to be correlated with the clinical findings. In this case, the patient had large patches of pigmentation involving the neck and the trunk, and the findings were consistent with the diagnosis of Erythema dyschromicum perstans. Similar changes may be seen in lichen planus pigmentosus, and in lichen planus actinicus. And some dermatopathologists view these as variants of lichen planus. Unlike conventional lichen planus, EDP typically is characterized by basket weave orthokeratosis rather than compact orthokeratosis. The epidermis, as we can see here, tends to be thin with the effacement of the reedy ridge pattern. There's active vacuolar change along the DEJ, and there is more of a patchy band-like infiltrate of lymphocytes within the dermis rather than a dense, robust band-like infiltrate of lymphocytes obscuring the dermal epidermal junction. And then finally, Erythema dyschromicum perstans is characterized by abundant melanin pigment within the dermis. If we didn't have clinical correlation here, a good clinical history, then one would need to sign this out as an interface dermatitis, and one would mention the possibility of EDP, lichen planus actinicus, lichen planus pigmentosus. I think one would also have to mention the possibility of a lichenoid drug eruption or a photolichenoid dermatitis. But this was a case of Erythema dyschromicum perstans confirmed by correlation with the clinical presentation. Moving on to case number 3, something entirely different. There's no skin here. Hopefully you were able to recognize that. No dermis, epidermis, or subcutaneous tissue. And what we have are sections through an organism, in this case, the larva of an arthropod. This particular structure is quite large, and it's characterized by a very thick chitinous wall that is kind of undulating. And then if we look out at the periphery of this wall, we can see regularly spaced ochre-colored setae, or spines. And these ochre-colored setae or spines are very characteristic, almost pathognomonic for a botfly larva. And so this was, these are sections through a botfly larva, which of course is the cause of myiasis. If we look at the internal structure of this organism, one can see that there's integument here, there's digestive tract, and there's also skeletal muscle. So it's the combination of this thick chitinous wall, coupled with especially the ochre-colored setae and the skeletal muscle and integument that are characteristic of a botfly larva. Another organism which is quite large and has a similar configuration would be the gravid sampley causing tungiasis. However, it lacks the ochre-colored setae that are so distinctive of the botfly larva. And if you see the two organisms in tissue section, the gravid sampley causing tungiasis tends to embed in the outer layer of the epidermis, whereas the botfly larva is typically found deeper in the dermis and induces a really robust inflammatory response. And I'm sure, as many of you know, myiasis is caused by the botfly. The female gravid botfly actually grabs a mosquito, lays the eggs on the mosquito. The mosquito, when it bites the host, human or animal, the eggs will drop off, hatch on the skin surface, and then the larva will burrow down into the skin. So this is a botfly larva. Moving on to slide number 4. Slide number 4, we have a shade biopsy. This has been bread loafed. And as we move to higher power, we can see that we've got a heavy infiltrate in the dermis. This is a kind of a dense, diffuse infiltrate filling the dermis. We've got a basket weave cornified layer and an epidermis of normal thickness. So our diagnosis here is going to be predicated on identifying the cells comprising the infiltrate. And as we move to higher power, we can see that the infiltrate is composed of large numbers of lipid-laden histiocytes. Now, we refer to lipid-laden histiocytes as foam cells or xanthoma cells, and you can see these foam cells or xanthoma cells dominate the infiltrate. So by definition, we've got a xanthoma here. And what's unique about this particular xanthoma and really allows us to make a specific diagnosis is that between these collections of foam cells or xanthoma cells, one can see, I'm going to get my pencil here, collections of extracellular lipid. And this extracellular lipid is really seen and specific for eruptive xanthomas. The triglyceride levels in these patients are so high that the histiocytes can't keep up, and the lipid tends to leak out into the surrounding dermis. So if you have eruptive xanthoma on a PIC list, or if you're looking at a xanthoma, an infiltrate with foam cells, you want to look for the presence of extracellular lipid to confirm the diagnosis of an eruptive xanthoma. This extracellular lipid can be pretty pro-inflammatory, and so it's not unusual to get an admixture of inflammatory cells, lymphocytes, and neutrophils early on within the infiltrate and mixed with the foam cells. So eruptive xanthoma, collections of foam cells, extracellular lipid. About the only thing that you might consider in the differential. On scan, one could think about something like granuloma annulare because we've got proliferation of histiocytes. In GA, however, rather than seeing extracellular lipid, we would see mucin between the collagen bundles. One could also think about something like a xanthelasma, but again, xanthelasmas tend to occur on the eyelid, and so the skin tends to be thinner. The dermis a little more loosely textured, and while one can see collections of foam cells, one does not see extracellular lipid in xanthelasma. Okay, moving on to case number 5. Case number 5 was a cute little lesion. We've got a dome-shaped papule here. This is a bisected shave. And at first blush, there doesn't appear to be much going on in the dermis. Collagen here may be slightly thickened. There's certainly not much in the way of an inflammatory infiltrate. The key to the diagnosis here really, though, rested in taking a look at the surface epithelium. We've got stratified squamous epithelium here, but if we look in the stratum corneum and the upper layers of the epidermis, we can see that we've got a parakeratotic stratum corneum. There's an absent granular layer, and the cells in the upper spinous layer have somewhat vacuolated or swollen cytoplasm. This constellation of features is very characteristic of mucosal epithelium. And if we look in the dermis, you can see that there are no hair follicles. We do have an increased number of vessels, somewhat thickened collagen bundles, and a few stellate fibroblasts. And so this has a lot of features of an angiofibroma. This is an oral fibroma, and oral fibromas may represent angiofibromas in some instances. A lot of times they'll develop at sites of trauma. And so sometimes these are referred to as bite fibromas as well. And this is a very characteristic histologic appearance. And again, it's important to recognize mucosal epithelium, stratified squamous, no granular layer, parakeratotic stratum corneum, and some vacuolization or swelling of the cells in the upper spinous layer. Moving on to case 6. Case number 6, we have a cyst. And the correct diagnosis in this case was a dermoid cyst. As we've covered in prior sessions, cysts are classified according to their lining. And so once you have determined on scanning magnification that you're dealing with a cyst, you need to go down and study the lining. Just to give you orientation here, We do have a little fragment of surface epidermis here. This cyst was very, very deep. It was actually scraped off the bone. And when you take a look at the cyst lining, you can see that it is composed of stratified squamous epithelium. Unlike the oral mucosa that we looked at, it's keratinizing with interposition of a granular layer. And there's the production of loose basket weave keratin within the central portion of the cyst. And so the lining resembles surface epidermis or infundibular epithelium, and that's very characteristic of a dermoid cyst. And then the other key feature is finding the presence of adnexal structures in the wall of a dermoid cyst. Here one can see a well-formed vellus hair follicle. In some areas, there were a few ducts in the wall of the cyst, and quite frequently, one can see sebaceous glands in the wall of a dermoid cyst. Again, we see mature sebaceous glands here, some unassociated with follicular units, and small vellus hair follicles. And so these findings are very characteristic of a dermoid cyst. Occasionally, one can see dermoid cyst in which areas of the cyst resemble a steatocystoma. Steatocystomas, or sebaceous duct cysts, as you remember, are also lined by stratified squamous epithelium, and they can contain sebaceous elements in their wall. However, the lining is a little different in a steatocystoma. In steatocystoma, one does not get interposition of a granular layer. The luminal aspect of the cyst has a scalloped border, and there's a thin eosinophilic cuticle along the luminal aspect. And occasionally one can see that type of differentiation focally in a dermoid cyst. But if you're trying to tell the difference between the two, okay, if there are areas of the cyst where one has a granular layer and basket weave keratin and no cuticle or undulation, one generally is dealing with a dermoid cyst, especially if you begin to see hair follicles and ductal elements within the wall. So this is a dermoid cyst. Slide number 7, I think, is a very pretty tumor. It's one of my favorites. And one can see we have a very vertically oriented neoplasm here in the dermis. This actually, I think, resembles a pillar or a pillar-type candle. And as we move to higher power, again, it's important to assess architecture. We can see that this proliferation is very well circumscribed, vertically oriented, and symmetric. One half looks like the other, so it does have a benign architectural configuration. And as we move to slightly higher power, we can see that actually we're dealing with an epithelial neoplasm in this instance rather than a mesenchymal tumor. And we've got these islands of epithelial cells, and they're embedded in a very fibrotic stroma. And you can almost draw a line around this stroma. The stroma here constitutes about 50% of this particular tumor. And that is very common in epithelial-derived tumors showing follicular differentiation. So when I see an epithelial neoplasm with a prominent fibrotic stroma, I begin to think about the possibility of follicular tumors. Well, let's go on down and look at the epithelial aggregates. And what strikes you as you begin to move in is that these epithelial aggregates are markedly variable in size and in shape. And this particular tumor is sometimes referred to as an animal cracker tumor, because if you look at the epithelial aggregates, and use your imagination, you can begin to see animals. This looks a little like the trunk of an elephant and the ear of the elephant. This looks a little like a bird flying. This looks a little like a kangaroo. And if you use your imagination and look around, this looks a little like a turtle. You can begin to see animal shapes in these tumors. So the animal cracker tumor. And yet, despite the variable size and shape of the epithelial component, when we look at each of these aggregates, the composition is the same. In each instance, out at the periphery, one can see a layer of cuboidal epithelium, which is somewhat palisaded around the periphery. You can see it in this aggregate. Again, this layer of cuboidal epithelium that is demonstrating palisading. I'm going to use my pencil here around the periphery of the neoplastic aggregates. Again, just to drive home the point, each is kind of outlined by this layer of cuboidal epithelium with peripheral palisading. If we look at the central portion of the aggregates, we can see in each one of these a proliferation of larger cells. These cells have uniform vesicular chromatin pattern, kind of abundant clear staining cytoplasm, but the cytoplasmic margins are somewhat indistinct. And then finally, our third component, in each one of these tumor aggregates, you can see that they're sprinkled with lymphocytes. So let's look at another one. Again, we can see the centrally located clear cells and a sprinkling of lymphocytes. And this constellation of features is characteristic of an adamantinoid trichoblastoma or cutaneous lymphadenoma. They all look like this. The makeup of the aggregates is similar. They're all embedded in a very fibrotic stroma, and they're characterized by this marked variability in size and shape. And this particular tumor is, again, regarded as a variant of a trichoblastoma. Trichoepitheliomas belong to the trichoblastoma family as well. So they're benign adnexal tumors with follicular differentiation. Moving on to slide 8. Slide 8, we have a punch biopsy. This was up near the neck, this bisected punch. And one can see that we have an infiltrative cells present within the dermis. The epidermis is hyperplastic. And it almost appears as if we have inflammation here centered around follicles. We've got a hair follicle over here. This contains a hair shaft, and we've got this downgrowth of squamous epithelium, which appears to be derived from follicular epithelium. Another follicle here containing inflammatory cells in the wall. However, if we go down and look at this squamous channel, we can see that it has somewhat of a pincher shape, okay? And there's a little cup-shaped invagination. And if we look beneath that invagination, we begin to see a mixture of inflammatory cells. There are neutrophils, and a little bit of neutrophilic nuclear debris, maybe some degenerated collagen. But what's quite striking is we see these bulky, refractile, eosinophilic fibers, which are hyperplastic. There's an increased number of these. And if we look at this channel over here, again, cup-shaped invagination, we see a lot of neutrophils and these fairly uniform, bulky, refractile fibers present within the dermis. These are elastic fibers, and the correct diagnosis in this case is elastosis perforans serpiginosa. It's one of our perforating disorders. Now, a differential consideration in this case would be one of the other perforating disorders, say reactive perforating collagenesis. And I find that some people struggle distinguishing reactive perforating collagenesis from elastosis perforans serpiginosa. In reactive perforating collagenesis, and I'm going to use my pencil here, one tends to get a broader transepidermal elimination channel. So it tends to be kind of broader, not so much cup-shaped, and extending from the base of the channel up to the surface, and it mixed with neutrophils, one will see transepidermal elimination channels of collagen fibers, which the collagen fibers tend to be a little bit thicker, more variable in size than these bulky refractile elastic fibers. And a lot of times they can be either eosinophilic or basophilic. What's characteristic about EPS, or Elastosis perforans serpiginosa, is again a narrow cup-shaped channel, resembles somewhat a vacuum cleaner, and it's sucking up these refractile elastic fibers. One could also consider the diagnosis of a perforating variant of pseudoxanthoma elasticum periumbilical PXE. In that particular instance, however, the elastic fibers that are being transepidermally eliminated are calcified. And so rather than being eosinophilic, they're going to be basophilic because they're encrusted with calcium. So Elastosis perforans serpiginosa can be seen in a variety of clinical settings, and I would definitely know the various settings in which we can see EPS, and of course, clinically, very distinctive. Case number 9, the correct diagnosis were in a deposition differential here is nodular amyloid. And in this punch biopsy specimen, this was from the arm near the shoulder, one can see that the epidermis is thinned with effacement of the reedy ridge pattern. And within the papillary and upper reticular dermis, there is deposition of material. You can see a striking contrast between the normal collagen and this material deposited in the dermis. Definitely has more of a blue-gray color. And as we move in, we can see actually that we've got these fissured deposits of pink and areas of blue-gray material. Some of it appears to be encasing vessels and some adnexal structures. And there's an associated infiltrate of plasma cells here. And this large deposit associated with the plasmacytic infiltrate, especially if it's fissured and pink like this, should lead you to consider the diagnosis of nodular amyloidosis. We can confirm the diagnosis with the use of Congo red or crystal violet stains. A nodular amyloid tends to be associated with an infiltrate of plasma cells because it is light chain derived amyloid. And this can occur solely as a skin finding or in the setting of systemic amyloidosis. So nodular amyloid, large deposits of fissured pink material and an associated infiltrate of plasma cells. And finally, our last slide. This can be a great mimic. This is a condition which can produce so many findings, and it's kind of like syphilis is clinically. In this particular biopsy specimen, punch biopsy from the trunk, one can see that we have an inflammatory infiltrate centered in part around vessels of the superficial and deep plexus. And if we kind of zoom in to slightly higher power, we can see that there's a split in the cornified layer. And in actuality, we have a little subcorneal pustule here. The infiltrate within the dermis is composed of lymphocytes, largely, and a few histiocytes. There's a rare neutrophil here. And if we take a look at the other piece, we can see we actually have a little focus here of suppurative folliculitis with some neutrophils in this follicular canal. Let's go back up to this top piece, because we know anytime we've got neutrophils in the cornified layer, we need to consider the possibility of infectious processes, and in particular, dermatophyte candida. Let me tilt this slide back down. And if we go in and take a look here, stratum corneum, there were readily identifiable septate hyphoelements within the stratum corneum. Let me get my pencil out here. One can see a beautiful hyphoelement here. Let me cancel that and get my pencil. One can see that it's branching. And let's see if we can go to slightly higher power. And one can see the septi within these hyphoelements as well. Readily identifiable in the H&E stain section, much more than one typically sees. These can be highlighted with a PAS or a GMS stain. We have another clue too that we might be dealing with dermatophyte. We've got a two-tone stratum corneum, the so-called sandwich sign. So if you take a look in this area, you can see that the outer portion of the cornified layer is characterized by a basket weave configuration. But near the bottom of the stratum corneum, the stratum corneum is becoming more compact and pink. And these can be thought of as two slices of bread. And when you see a two-tone stratum corneum, always look between the two slices of bread, because frequently you'll see refractile hyphoelements there. So we talked about two clues for dermatophytosis: neutrophils in the stratum corneum and a two-tone stratum corneum. A couple of other changes that should heighten your index of suspicion for dermatophytosis. Anytime you're dealing with a spongiotic or eczematous dermatitis on volar surfaces, one should think about the possibility of dermatophytosis. And finally, if you've got a psoriasiform dermatitis, one with epidermal hyperplasia, and a compact cornified layer, you want to make sure that you look for the presence of dermatophyte. In that latter instance, where the cornified layer is compact above a psoriasiform dermatitis, it's very difficult to see the organisms. And in those instances, you almost always need a PAS or GMS stain to identify the organisms. So there we have it. And if you have any questions at all, again, please feel free to reach out to education@sagescx.com, or you can email me directly. And again, as always, if there are any topics that you would like us to cover, or any topics that you'd like addressed in these sessions, please feel free to reach out to us. We're always looking for suggestions. Hope everybody has a great evening. Thank you.